So I'm delighted to welcome you all to the second seminar in our Brunel seminar series that's focused around physical activity and sedentary behaviour during COVID-19. And I'm delighted to welcome Professor Tom Yates today. Tom is a Professor of Physical Activity, Sedentary Behaviour and Health based at the Leicester Diabetes Centre. It's situated within the University Hospitals of Leicester NHS Trust, and he works for the University of Leicester as well in their Diabetes Research Centre. And I'm delighted to have Tom here today to talk to us about the challenges and opportunities of conducting physical activity and sedentary behaviour research during COVID-19, and giving us a perspective and insight in relation to what he's been doing in this field over the past 12 to 18 months or so. So Tom, I'd like to pass over to you now, and then there'll of course be an opportunity for questions and answers once Tom has finished his talk. Okay.
Thanks very much, Dan, and welcome to everyone. So yeah, as Dan said, I'm just going to go through sort of the research areas we were working on pre-pandemic, and then what happens as research areas during the pandemic, really what opportunities and challenges were there. It's been a really exciting time for research, but also very challenging in some areas as well. So I'll go through some of those perspectives from our group in Leicester, and then just finish with a couple of conclusions. I mean, it's not going to be a particularly long presentation. I don't want to bore you all to death over an hour or so. So I'll keep it relatively short, I think, maybe around half an hour or so, and then leave time for questions at the end, and it'd be good to have a good discussion with you all. So just to give you an idea of our starting point, where were we starting from, and what is our research strategy in Leicester? So our strategy is really closely linked to the translational research gaps that were identified by the National Institute for Health Research when it was set up 10 to 15 years ago. And it was recognised that it's really difficult moving from basic science through to improved patient care. Often basic scientists weren't addressing questions that were relevant to clinicians, or clinicians weren't picking up on basic science that was has a potential to lead to improved care. So there's been a real focus nationally with the National Institute for Health Research to really try and address this and make the throughput quicker, and to also make sure research doesn't get lost in that research death valley. So in Leicester, we committed to doing this with physical activity and lifestyle research around the two main translational gaps. So that is moving laboratory-based basic research through to clinical medicine, and then implementing new treatments for patient populations or groups. Our research is funded by funding structures that support these two translational gaps. I'm really lucky to work within the Leicester Biomedical Research Centre, which is currently £11.6 million over 5 years, and is actually just coming up for renewal. And that has 3 research themes, of which lifestyle is one, and so that really supports our infrastructure. And we've also had MRC projects and also charity funded projects as well that will fund that early phase translational research. And then across the second translational gap, we also, most of our funding comes from the National Institute for Health Research through their programme grants for applied research, their HDA funding portfolio, and also the ARC East Midlands, which is for the implementation side of things. Also public health and policy research funding programmes as well. And so our research, because we work in a medical establishment and the diabetes centre, our research is primarily focused on long-term conditions, particularly diabetes and how we can use exercise and lifestyle-based therapies within that context, but also occupational and public health as well. We have a fair bit going on in those areas. So we achieve those translational gaps by working across the research spectrum. We have a portfolio of epidemiology and measurement, which is used for hypothesis generation or to inform public health. We then test our hypotheses with experimental trials, looking at optimal dosing or frequency across different intensities of exercise, mechanisms and sort of clinical outcomes. We go from there into more phase 3 effectiveness trials, you know, the HTA type trial remit, where interventions are typically done over 1, 2, 3, and even 4 years. Recently, we've had a physical activity trial that's finished in well over 1,000 people. That was funded by HTA. And then if we can prove they're effective there, we then move on to work with NIHR to see how we can implement those interventions into routine clinical settings. And our two exemplars of that have been our diabetes prevention work, where our diabetes prevention programs are implemented through the NHS Healthy You diabetes prevention program nationally, and our sedentary behaviour work as well, which has been led by Charlotte Edwardson, around developing occupational interventions to reduce sedentary time in office workers, have really taken off as well. And sort of across all those different research pathways, we have a really strong embedded measurement infrastructure that's led by Dr. Alex Rowlands and Charlotte Edwardson, based on accelerometers, but that's really taken off in terms of using 24-hour behavioural profiling to understand what people are doing and how that then links to health outcomes. So just to take you through some examples of what this has meant in terms of our research outputs, focusing in particularly to the things that then became relevant during the pandemic. So our epidemiology work in Leicester is really run in collaboration with the Leicester Real World Evidence Unit, who sit 2 or 3 doors down from me and host some really great statistical and epidemiology colleagues who can support our physical activity research. Prior to the pandemic, we had lots of activity within UK Biobank, and some of our sort of flagship or highest profile outputs in that, or the ones that have captured the public interest the most, have been our work around walking pace. And this just shows 2 examples of outputs from that work. Walking pace within UK Biobank is probably the strongest marker of health status, pretty much bar anything else, which has been absolutely fascinating to look at. So that we had an early publication in the European Heart Journal showing that brisk walkers compared to the slow walking reference here, slow walkers compared to the brisk walking reference here had a much higher risk of all-cause mortality and cardiovascular mortality. And really, no matter what we adjusted for, beyond a certain point, that association was not attenuated and remained really robust against a whole host of possible confounders. And then we extended that in a series of Mendelian randomization, GWAS studies, but also studies looking across different lifestyle factors. And this to me was pretty fascinating. It's difficult to maybe get to grips with what's going on here quickly, but essentially the green line here is the survival of walking pace across different other lifestyle exposures, whether it's dietary intake, sleep, and BMI. And really the headline from this is that if you are a fast walker but have otherwise unhealthy lifestyle practices, you're going to live longer than if you're a slow walker, but have otherwise very healthy lifestyle practices, and that includes BMI. So it needs to be careful not to make too much of this etiologically, but in terms of risk prediction, it just shows the power of a very simple question around walking pace and the prognostic ability of that in terms of looking at health outcomes. And we've extended this with also C-index work, which are better markers of prognostic ability as well. We also have developed in-house local data sets, and we've done this across a whole range of diseases. But the one that became relevant later on was the CODEC study, which is a cohort of people with type 2 diabetes that we've recruited not just in Leicester but throughout the East Midlands, and really detailed phenotype them with different outcomes, including wristwall acceleration. The aim really was to look at the impact of sleep and chronotype, but it's allowed us to do a whole lot more than that. Some early outputs from this from Joe was looking at the impact of chronotype, so whether you're a lark or an owl, and the impact of this on physical activity behaviours, because we know that people with evening chronotypes, the more owls among you, actually tend to not do so well in terms of health outcomes, and understanding why this might be is important. There's a whole host of potential reasons, but what we're showing here is that evening chronotypes undertake less activity and have high levels of sedentary behaviour, and also do those activity bouts at different times in the day to morning chronotypes. So that may well play into, at least partly, into some of that differential in health outcomes. In terms of our experimental portfolio, we have well, before the pandemic, we had a very bustling exercise laboratory, which we used as a platform for undertaking experimental crossover trials. We've had a focus right across the activity continuum, from standing and light activity walking and sedentary break type work, all the way through to high intensity interval training, and looking at the impact on that on insulin sensitivity, glucose control, lipid profiles, etc. What became relevant to the pandemic is that we have also increasingly had a focus on how these responses differentiate across different ethnicities, because we know that ethnic groups don't necessarily respond in the same way to a given bout of exercise. And in these two publications, what we've found nicely was that during sitting, South Asians have a higher level of insulin resistance than white Europeans. After a bout of walking, that difference is much lower, and the reduction in South Asians is greater than it is in white Europeans. So that interaction is statistically significant. With breaking sedentary time, which is here, you're not completely getting rid of the difference, but nonetheless it's reduced. With high intensity interval training, we saw a similar pattern where there was a greater reduction in the South Asian community compared to white Europeans. The high intensity interval training gave a greater benefit compared to continuous training, and there was now no difference between these ethnic groups. So the difference in insulin resistance that we were seeing has been normalized after a bout of high intensity interval training. So pretty fascinating stuff, but very relevant to Leicester because it's multi-ethnic communities, and this is something we really want to build on in the future. But this sort of ethnic differential in health has obviously been unmasked and become much more talked about during the pandemic. In terms of our clinical trials, we've had a whole host of diabetes prevention and sedentary behaviour work that has been for a minimum of 12 months and the maximum of up to 4 years. our Propel's HDA trial has just been submitted for publication, which would be another one to add to this list. But we've really majored on, so far anyway, on diabetes prevention work and occupational interventions for reducing sedentary time, including the smart work intervention here, which was published in BMJ. So this has been this activity has had some impact during the pandemic, which I'll come on to later. So how we adapted this pathway for the pandemic, and really my major focus has been on using our epidemiology. The work that we were doing has really blossomed and grown exponentially in during the pandemic for some very clear research outputs and reasons. But the first thing we were able to do is to say, actually, we've got some really good cohorts that we've collected recent data on. It'd be really easy for us to go back to those same populations and get some additional accelerometer data during lockdown to see how people's behaviours were changing. There was a concern, I think, that people, because of lockdown, were going to become much less active, which could then potentially impact their metabolic health, particularly those with chronic disease. So we were actually able to do this pretty proactively with the CODEC study, which was that database with those with type 2 diabetes recruited across the East Midlands. So a very easy idea, actually not so easy to implement, because we had to go through the laborious process of putting in an ethics amendment that was prioritised but still took some time. We had to register with the NIH, our COVID research database, and we had to work with our HR department and the hospital trusts to get clearance for our university staff to come onto site to actually get those accelerometers ready and then send them out to participants with sterile wipes. And to have all that infection control stuff in place for this research. But nonetheless, we were able to do it. We were able to do this just at the end of the first lockdown, and what we found was that the results were going as anticipated, but actually the effect was not as big as we were expecting. So in terms of overall activity, which we measure in milligravity units, there was a reduction of 1.7 units. We've had a publication in the British Journal of Sports Medicine arguing that 1 unit is a clinically meaningful difference, or is the minimum clinically meaningful difference. So this difference here is potentially clinically meaningful, but it's not that big really in the grander scheme of things. And people had increased their inactive time measured with a wrist-worn accelerometer, but it's sort of analogous to sedentary time, by almost 22 minutes. So again, an increase, potentially clinically meaningful, but right at the bottom range of what would be considered to be meaningful. Interestingly, we also found that although overactivity levels had reduced, the pattern of activity had actually changed, and may have even changed for the better. You remember during the pandemic, particularly the first lockdown, that there was a big focus on getting out for your daily 30 minutes of exercise, and that's what we were regularly told we're allowed to do, otherwise we should be staying at home. And it looks like even in this cohort with type 2 diabetes that there were more people undertaking longer bouts of activity than there had been pre-pandemic. And so this just shows the number of people achieving 30 continuous minutes at baseline and then during the restrictions. And you can see that the number of people that were doing no continuous bouts dropped during the restrictions and increased for doing 30 minutes on 1, 2, 3, 4, 5, 6 and 7 days. Before the pandemic, nobody was doing 7 days of 30 continuous bouts of moderate exercise, but there were a couple that did it during the restrictions, which was interesting, and again not wholly unexpected, but maybe not wholly expected either, in that we were finding maybe less of an impact on overall activity levels, but people's pattern of activity seemed to be changing. We don't know yet what impact it's going to have on people's health status, but it may not be as extreme or as negative as we were perhaps expecting. And so one thing leads to another. So our ability to react proactively and send out accelerometers to participants and put that infrastructure in place led us into the opportunity to work with a very high profile Leicester physician, Chris Breitling, who's a respiratory physician, leads the respiratory arm theme in the BRC. He received a very large grant, I think it was over £8 million in funding, to establish a cohort of hospitalised patients with COVID-19 and to really look at their trajectory after hospitalisation, and then to have a more detailed cohort within that of the initial aim was 4,000 people to take additional clinical data and research specific biosampling. And we were actually able to work with him and his team, particularly Rachel Evans, to embed accelerometer assessment within that more detailed phenotyping. So that came with funding to fund a research associate, and we are currently sending accelerometers all around the country, including in Scotland and I think Northern Ireland as well, for people to wear the accelerometers for 7 days and getting all this data coming back. And we've just put in a request to look at that data in terms of how it corresponds to the clusters of symptomology that they've recently published. And you may have seen that all over the news a couple of weeks ago. And so, I mean, that's been absolutely fantastic for us because it's funded an additional research associate, and it's working with a very high profile clinical team and being able to enhance what they can collect with our physical activity skills. So next slide. Because we were working with UK Biobank, we were able to very quickly just put all our focus into using the projects that we had to do COVID research. I mean, Biobank's a really fantastic national resource, 500,000 people, detailed phenotypic information, and they linked that database to Public Health England's testing database. So anybody that went to get a COVID test was then linked within Biobank, was linked, and we know whether they had a test, what the test result was, whether it was in hospital or the community, and then whether people died of COVID-19. So we were able to look at this almost immediately, and the first thing we had to do was really try and work out what the data was telling us and how it should be analysed. And we pulled some of this work together into an open access publication that's on Wellcome Open Research, because you have your full cohort, you have the people that have been tested, you have the people that are testing positive in the setting they were testing positive in, and then you had the people that died. And what you take as your outcome and your comparative data set actually has quite a big impact on the associations that you find. And there's reasons around collider bias and other biases in the data set as to why that would be. But nevertheless, even with these limitations, we've been able to do some really nice analysis. This is one of the first bits that we did looking at, this is just looking at positivity, but it's become very relevant later on, looking at ethnic differences in the risk of positivity within UK Biobank and how those varied across white and ethnic minority groups. To me, this bit here is the most interesting. It shows that if you have an ethnic minority person, a white person who are relatively lean, then on average there's no difference in risk between those two individuals. The difference in risk only becomes apparent as magnified as BMI is increased, which an early indication that not everybody, well, BMI is a risk factor, but it could actually be impacting some communities more than others. We went on to work with the ISARIC team and got access to the ISARIC database, which is much larger. In this case, 60,000 patients who have been hospitalised throughout the UK. And we had a look at this same phenomenon with hospital outcomes. So whether if people are admitted with COVID-19, what's the risk of going into critical care, receiving mechanical ventilation, or dying in hospital? And again, we can see this pattern of risk differentiation between ethnicity and obesity. But if we look at the mortality here, we can see that the highest risk group for any outcome are Black ethnicities with obesity, and ethnic risk in terms of the people without obesity was significant, but it was actually marginal, really. It was only a very small elevation in risk, but it was the interaction between ethnicity and BMI that really seemed to accelerate the risk in minority ethnic communities, particularly Black communities in this case. And I mean, ISARIC is just an absolutely fantastic data set to work with, and we've got several other ongoing work in this area. Going back to UK Biobank, another one of our publications looked at how obesity interacts with walking pace. I've talked before about the importance of walking pace, and interestingly, this has been borne out by COVID-19 outcomes as well. So within the whole UK Biobank population, the risk of developing severe in-hospital COVID-19 or dying from COVID-19 is really high, or much higher in slow walkers. You can see you're going up here up to an odds ratio of 4, and it doesn't really matter if you're a slow lean walker or a slow obese walker, your risk is high regardless, and it's higher than if you're a brisk obese walker, both for severe disease and mortality. So some of you may have seen this in the news. I think it's really captured the media's attention and was very well disseminated in the media, much more so than some of our other research, maybe because it had quite a simple, clear message. One of my PhD students, Monica Makuti, is following up on this and looking at how walking pace compares to other frailty indicators in terms of its actual prognostic significance using the C-indexed statistic. Because proof of association does not necessarily mean proof of prognostic discrimination, and the C-index allows us to look at that in a bit more detail. But the headline from this is that in terms of all the frailty indicators, walking pace was by far the best prognostic discriminator. And even if you looked at Fried's overall frailty index, which is not frail, moderately frail, or frail, just a simple question around walking pace actually performed better than the overall Fried's frailty index. And walking pace remained a significant predictor of severe disease, even after adjusting for known predictors that included other risk models, including ethnicity, deprivation, comorbidities, and body mass index. And we sort of took this result here to mean that if you know nothing else about people apart from their age and their sex, if you ask about their walking speed, that's going to give you a lot more information about the risk of COVID-19 versus all these other frailty indicators. Again, working with the fantastic team that I do, we have a whole different host of options and novelty in what we can do. And one of them is around accelerometer data. So Alex Rowlands in our team is a senior internationally known expert in accelerometer data. And he's actually downloaded and reanalyzed the accelerometer data from UK Biobank to generate some metrics that are not at the moment available within the more commonly available. And we looked at some of these metrics and how they relate to COVID-19 risk within UK Biobank, and this again was early data, but was starting to tell us actually something quite interesting. And the interesting bit was that if we looked at overall activity levels, or MVPA, you can see here the confidence interval, although it's going in the right direction, is crossing the null, so it wasn't significant. But what we actually found was that if we try and differentiate out sleep activity from waking activity, looking at the most active 16 hours and the least active 8 hours as an indication of people's sleeping time, the risk became greater and significant. So how active people, how restless people are at sleep obviously contributes to somebody's overall daily activity level, but is not healthy. So if you're adding that on to overall daily activity volume, you're attenuating some of the impact that activity is actually having. So here, people's most active 16 hours was associated with a lower risk, but how active people were during the least active 8 or 6 hours gave people a higher risk of COVID-19 because of the link to sleep disruption. And the balance of activity against rest was giving us the sort of the best metric for COVID-19 risk, and also sleep variability as well, or the variability in those least active 8 hours was also associated with increased risk, and that was published in an early article in Mayo Clinic Proceedings, and Alex is following up on this at the moment with the current data set. Really the thing that's captured my imagination the most has been the ability to use the opportunity from the pandemic to really do some deep dive and increase the range of skills that we can then apply into physical activity research. And one of those areas was around looking at mediation analysis. So this was an analysis that was looking at the risk of positivity, severe disease, and COVID-19 mortality in ethnic groups, and how much of that is mediated by deprivation. So just looking at the example of mortality, expected figures here, minority ethnic groups have 4 times the risk of dying from COVID-19 than white Europeans do, which was known. This is really stark. If you deliver an intervention within the whole population to lift the 25% most deprived out of deprivation, you're going to get rid of almost half of that excess risk. If you move the 50% in the whole population, regardless of their ethnicity, out of deprivation, you're then pretty much normalizing the risk between ethnic groups, suggesting that we're seeing an elevated risk in ethnic minority communities, not because of some innate biological factor, but simply because minority ethnic groups tend to live in more deprived communities, and it's that link to deprivation that's really driving this excess risk. The fascinating thing to me was that as physical activity researchers, we tend to just adjust and then assume that the reduction in risk is the degree of mediation, but that's really not correct, and not the way we should be looking at mediation analysis. And so that analysis was done with a 4-way decomposition mediation model, which is quite complex. And it also relates to the DAG that you draw as well. And we had some really very stimulating conversations internally, but then with the reviewers of the paper around how the DAG is drawn and what that means for the analysis. And so this is a really nice model that we can then apply into physical activity research in the future, looking at what mediates the impact of physical activity, for example. We've used this analysis, the opportunity that's been afforded by our ability to react proactively within some of these epidemiological frameworks to then actually start working nationally now. So we have funding from UKRI and Department of Health and Social Care, but also more laterally, we've got a relatively large grant just before Christmas from Health Digital Research UK to apply our modelling and knowledge that we have generated into national data sets, and the pandemic has just accelerated what's possible on a national scale. It's blown apart some of the barriers that were existing before and just allowed people to be much more proactive and think about things differently in terms of using those national data assets. So we've got funding to work with ONS, to work within a trusted research environment, to then link data sets that come from NHS Digital, which includes all GP records for England or hospital records for England, and positive cases and surveillance cases, and link those to census data. So all that demographic data that you've recently filled in for your census statements, we can link all of that to mortality data. So we've got a really nice ability to work across clinical records, including factors like BMI, census data, where people live, deprivation, number of people in the house, region, etc., and then link that up to mortality. We're also working with the vaccination data as well to try and work out why we're seeing this signal in ethnic minority groups that they have a lower take up, and again, all that linked vaccination data is available to ONS and will become available to our research team. And so that's been a really stimulating process, and also quite a sharp learning curve as well, and has obviously involved a truckload of paperwork as well to even get this far. But just really fantastic opportunities that presented themselves. In terms of our experimental research, as for all of you, that's really been very challenging for us. And a credit to Nicole, who you can see there in the picture, and our staff who have worked with a hospital trust to enable us to at least get some activity progressing through the lab in terms of our VO2 max testing and exercise training. But that has come with a 10-page risk assessment that has to be filled out for every study, and quite an onerous ask of the technical staff, who have to wear full PPE and then have to do quite a deep clean after each participant has been through the labs. So we're by no means running at full capacity, but we are at least able to have some capacity going through. Time's running out, so I won't go through all of this in too much detail, but this is just a journey of a poor PhD student who had her first participant through just as lockdown happened. Really quite, she had a horrible time, really. And then had to go through this really painful process with sponsor and ethics around, she can't see participants anymore. She has to complete a PhD. What can she do? So we put in an amendment to try and run the intervention, some of the assessments remotely, but she got stuck in circular conversations with sponsor that took ages to resolve. Then she had to go through the HRA process, and eventually got the green light just before the new year, at which point everything started to shut down again. So PhD students and early career researchers have really been impacted by this, and as examiners and people that are going to be examining these students in the future, I think we will need to be very mindful of that. But alongside this, in terms of that home remote monitoring side of things, we were lucky to get a grant of £7,000 to really put some of this infrastructure in place to deliver exercise classes remotely to our participants. And we are doing that. I think at the moment we're doing that through MyZone, which is a bit of software that allows us to deliver exercise classes remotely to participants while also monitoring heart rate and some indicators of exercise intensity, either one-to-one or within classes. So we're just getting that technology set up at the moment around using being able to have a monitor in the gym, enabling participants to use Google Chrome or whatever else they use to then link that up in their home. And we're even talking about delivering exercise bikes, or maybe not now, but in the future, treadmills to people's homes to actually allow us to do that supervised one-to-one intensive exercise training. But that's coming with a whole lot of additional governance issues that we need to think about, and we're resolving at the moment. In terms of our wider portfolio of research, again, it's been very project specific. Just before the pandemic, we got notification that we've been successful with an MRC funded project looking at diabetes remission through diet and exercise. So the pandemic was actually quite timely for that project because it's given us a much longer time to set things up, really have a much more detailed think about the protocol and go through every single issue that we can conceivably think of. So we've ended up with a protocol that's going to be much more robust and in need of much less need of amendments because it's given us much more time to think about it. Charlotte's Smart Work and Life study was absolutely flying. Was a really great study that she had set up, multi-site study within council workers looking at delivering a reduced sedentary intervention. Because it had that work occupational setting, all of that obviously stopped. So the funding NIHR said actually you can only do your 12-month follow-up. You can't do your 24-month follow-up. So that study was stopped early, albeit still at a time point that would allow for some very meaningful analysis to be done. So just to finish with some parting thoughts, really, what's driven our ability to react and have success in Leicester for our physical activity research and has allowed us to be impactful and still be productive is that we had a very diverse portfolio of research pre-pandemic, and we were able to use that, the bits that would work best during the pandemic to really give those an uplift. So if you have a diverse portfolio, you have a much greater ability to react to things as they come up, because some of these parts of the portfolio will really flourish and others will be more challenging. Really use your networks to form new collaborations, and you know, it's a good time to sort of take stock and think think about doing new things in the future. I've developed some really great grant applications and grant submissions in the since Christmas, working with Rachel Battram at UCL, which to me was a completely new partnership, but it probably wouldn't have happened had the pandemic not hit. In terms of being productive and impactful, the only way that we can do that in Leicester is because we work with leading clinicians. Without that, you know, the work that we undertake simply would not have the impact it does. And I'm not blind to that at all. I do my bit, but I'm only able to do that because I work with these leading people, including Cameron Quinty, who is the chair of the Ethnicity subcommittee for SAGE and is really deeply involved in all the policy work. And so our research has informed what SAGE has done, but it's also allowed us to have our finger on the pulse and react quickly to policy questions as they're coming out, and also have a supportive family. I don't know about the rest of you, but there's been a perception that working at home is perhaps easier, or we spend less time working. Actually, the opposite has been true for me and my team, in that our working hours have just rocketed through the pandemic. And so, yeah, you had to have a good support bubble around you to be able to react and continue to be productive. And I think that's it. So happy to take questions now. Oh yeah, just some acknowledgements to co-workers who have supported that portfolio of research that was shown.
Great, thanks Tom. Great to get an insight about the research that you've previously done and then how it's adapted, changed and advanced since COVID-19. Definitely opened my eyes to opportunities that we need to consider in terms of the types of studies that we can actually generate at the moment. We've got a number of Q&A, a number of questions that have gone in, but I wondered if you mind if I just kicked off with a question first. I mean, so the research that you've been doing and you've shown us that you've published so far as a result of the pandemic, it's fascinating. I mean, how do you now see the work that you're doing impacting on health policy practice going forward from now?
So, I mean, in terms of the epidemiology, I think that's relatively easy to answer and see how that actually has an effect, because what we're highlighting in our research at the moment is looking at why vaccination uptake, for example, is lower in some ethnic or religious communities. And so you can see how that's going to have an immediate impact on public health policy and community engagement with groups where there is known to be vaccine hesitancy or low take-up. And similarly with BMI as well, we've got some really nice new data we're working on, looking at the ethnic differential nationally in terms of the association with BMI. I've also, so this funded research and the work that we've been doing has also allowed me to talk to new people that I would never have talked to before. So special advisors to the Prime Minister and Cabinet Office, for example, those types of people who you can directly talk to about your research and why it's important and what it might mean for public policy. You know, obviously that doesn't always get through to the Conservative government, but I think nevertheless having those conversations is important. And I think the things around fitness and walking pace have not been really widely known at sort of policy level. So being able to produce outputs and talk to people about those, I think, is important, and is getting the physical activity and movement agenda on people's maps. And I think that's easy to see where the impact's coming from. I think there is going to be some impacts around how we deliver physical activity interventions and engage physical activity promotion remotely. But I was telling Dan before this seminar started that we've actually done some PPI, and what that showed was that whilst remote digital interventions are possible and the way we can do those is becoming ever more sophisticated, people still really value that one-to-one support, including for exercise supervision. So I don't think it's going to be the panacea that some people think it is. I think people are still going to want to come in and see people face to face.
Good, great, thanks. And I've actually got a question in the Q&A that's related to what I just asked as well, and it's from a practitioner who is involved with the National Diabetes Prevention Programme. So from Elliot. So you mentioned the difficulty of the transition of research to clinical application, such as with the NDPP. So the question is, how long do you think it would take for new research that you're generating at the moment to be applied, presented and received by patients within the NDPP? Could it be relatively quick, or do you think it's going to be quite a long process?
That's a relatively difficult question to answer, and I think it depends a bit on what we're talking about. So, for example, we've had a really strong focus in our research in around sedentary behaviour. So, traditionally, diabetes prevention is thought about, very traditional forms of 30 minutes a day of moderate activity, and really not more has been talked about more than that. So I think those are the type of messages that can be translated through quite quickly, especially when we actually do the experimental research, but also a link to the people that are delivering the National Diabetes Prevention Programme or the part of the Commission framework, because we can work with people delivering the curriculum to make sure some of those messages are starting to be prioritised and come out within the curriculums of the programmes. So I think those types of things can be throughputed very quickly where you have that good translational infrastructure in place. The other one I think is a really good example of this has been the total dietary replacement. I know it's controversial and people either love it or hate it, but the speed at which that has gone from a good quality publication in the Lancet to actually an embedded pilot within the NHS has been, to my mind, very swift. And so it shows that where there's a willingness on the part of the NHS, or you're hitting a right clinical need at the right time, that translational pathway can be very quick. So yeah, but it does sort of depend on which area we're talking about.
Mm-hmm. Yeah, of course. Good. Okay, great. Someone's asked a question regarding the experimental study that you presented findings on in relation to metabolic responses to breaking up sitting in South Asian and white European individuals, and they asked if you observed any effects on the other variables apart from insulin, which you presented. So were there benefits in any of the other metabolic biomarkers?
I think in terms of the ethnic differentiated response, it was definitely insulin sensitivity where we were seeing the major effect. There were other effects across both ethnic groups, most notably blood pressure, where we were getting clinically significant reductions in blood pressure throughout the day. But I think that was consistent in both ethnic groups. We've also used that data set and just finishing a paper now looking at cross-sectionally the impact of different types of measures of movement on physical function in white Europeans and South Asians. And actually we see the opposite. We see that in white Europeans there's a very nice dose-response relationship between the more active people are and the better their muscle health and physical function, where we see a much weaker and non-significant association in South Asians. So there does seem to be something around the differential response across ethnicities, where sometimes the response is greater, but other times it's weaker depending on the outcome that we're looking at.
Okay, great, thanks. So I've got a few more questions. May not get through all of them, depends on how long the answers are. So from your experience, what specific post-COVID public health lifestyle interventions would you recommend, and in particular for ethnic minority groups?
So I think that's a really difficult question, and actually you may be aware that there's a call out at the moment by NIHR for long COVID in non-hospitalised patients. And I think there's a need for a whole range of different things. There's the post-exercise malaise that people are talking about. There's brain fog, there's psychological health, and there's poor physical function. So I think the intervention really does need to be tailored to the individual. The other thing that we're aware of, and I don't think has been addressed properly, is that obesity is such a strong risk factor for disease severity. And it also seems to be that people long COVID are more likely to be obese on average than people that recover quickly. So the other thing that we need to consider is how do you implement weight management services or programs effectively for people recovering from COVID-19 to help with that recovery pathway. There's a whole national effort around rehabilitation, your COVID recovery, and NHS Digital are, I think, working on and launching a fully digital rehabilitation program, which will include exercise-based rehabilitation for people recovering from COVID. In terms of the ethnic minority communities, vaccination remains a live issue. And I think the overall messages around tailoring and physiotherapy will be just as important, or maybe even more important there than anywhere else. But it's really the community engagement and how do you set up services effectively for those communities that they will then take them up and provide proper language support and things like that, which I think will be the challenge. But the need, I think, is consistent across age groups and ethnicities.
Okay, thanks. And then there's a few questions related to your research on walking pace. So I'll try and summarise them maybe into a couple of questions. So one person is particularly interested to know how you'd actually communicate those findings into public health messages and in public health promotion as well. You got any suggestions or thoughts on that? Or have you tried to do that?
Yeah, well, so I think that comes in two formats really. The first format is simply for risk prediction. So what I've tried to argue for a while and have undertaken the research to back it up is that walking pace is actually a really good prognostic marker that tells us something that traditional risk factors don't. So if you're a doctor or healthcare professional, asking people how quickly they walk can be a really good indicator of their overall health status and a really good indicator of their risk of going on to develop cardiovascular disease, for example. So it can act as a flag, really a red flag. If people are reporting a slow walking pace, then we know that they're going to have a likely high risk of future health outcomes. But there's also, I think, an ecological message in there as well, and it's probably the question I get asked most. If I walk faster, will I get healthier? And I think the answer to that is needs to be more nuanced, because of the way the research has been conducted in terms of observational research. But we do know that, especially from rehabilitation programs, that if you can help slow walkers walk more quickly, you will increase their fitness and improve their survival chances if they've got poor underlying health or long-term conditions. So there is certainly a public health message out there as well. So yeah, I think it's around when you do have to walk, and we all have to walk in our daily lives, or most those of us who are able to have to walk, if it's just from the car into the house or pottering around the house in the evening, you know, where you do have to walk, try and walk briskly and try and walk more as well. And Public Health England have the app, don't they, around the 10 minutes a day, which I think is quite a nice message, but to make that 10 minutes as brisk as possible.
Great. And just maybe one last quick question here. So this is from someone, again, in relation to the walking pace study. And the question really is around consideration of individuals who may not be able to walk quickly, such as those with lipodema, who may have unequal distribution of fat, so have got more fat in the lower body, heavy legs, difficult to walk slowly. Is that something that's been considered, or should we consider that? How do we, what considerations do we need to make for those kinds of individuals?
Yeah, so that's a good question. So I think the majority of us can walk, and the majority of us can walk quicker than we do. But there are certainly people that can't walk or find walking very hard, particularly with chronic disease. We do have a program of work at the moment in our centre looking at people with diabetic foot problems and foot ulcers, because that's one of the conditions where you're told not only that you can't walk, you shouldn't actually be putting any pressure or load on that foot at all. So you should be offloading with sitting down. And we've undertaken some experimental exercise, but also have a larger training study on the go, looking at the impact of arm exercise. So actually, what's true for walking is also true for upper body exercise. Try and do it a bit more intensely and for a bit longer. And if you can do that, you're going to get very good health benefits as well if you can't walk.
Okay, great, good. Well, that brings us to 11 o'clock, so we better draw it to a close. Thanks, Tom, for a great talk and great responses to the questions afterwards as well. Thanks to the attendees for joining us.
Great, thanks so much, Dan.